right, we're going to get started here. Good morning, everyone, and thank you for taking the time to join our grand rounds this morning. And special welcome to our new house staff, our interns for whom this may be their first grand round. So thank you and welcome. I have two speakers to introduce today. First is Dr. Jennifer Duchon. She is an associate professor of pediatrics. She holds board certifications in pediatrics, neonatology, and pediatric infectious diseases. In addition to serving as the pediatric hospital epidemiology and director of antimicrobial stewardship for pediatrics, she also practices neonatology and pediatric infectious diseases in the Mount Sinai Health System. And our second speaker is Dr. Gopi Patel. She is a professor of medicine in the Division of ID here at Sinai. She completed both her IM residency and ID fellowship here at Sinai. She currently serves as the hospital epidemiologist for the hospital and the medical director for the antimicrobial stewardship across the health system. In these roles, she leads efforts to prevent healthcare-associated infections, promotes the responsible use of antimicrobials, and enhances emergency preparedness. She has played a central role in the hospital's pandemic response, as well as and is recognized for advancing system-wide strategies that promote quality and safety. So if you can please join me in welcoming our two speakers today.
Thank you. I'm going to start, and Dr. Patel is going to join about halfway through. So the title of our talk is The Measles Comeback Tour. Are we ready for the reunion? This was chosen by Dr. Patel. I'll caveat that I'm an extremely nervous speaker, and I'm used to speaking to neonates. They don't talk back so much. Bear with me. Whoops. So we have no financial disclosures. We're both fully vaccinated and are advocates for vaccines. We maintain that public health is a global priority, not just local. And I disclosed I'm older than Dr. Patel. My vaccine records are on the left. I was born before MMR, but I did end up getting an MMR because when it was time, it had just become available. Dr. Patel's document is on the right, and she is a global traveler in terms of vaccinations. So our outline is going to be some science, some history, some storytelling. Dr. Patel is going to do a lot of discussion about our recent outbreaks, some that shaped public health response, our Mount Sinai measles response, and the current state of vaccination, as well as some very difficult conversations that we have to have. Dr. Ratner, who wrote a book called Booster Shots, was one of my attendings when I was doing my pediatric ID fellowship. It's a very interesting book, uses measles as a worked example to some of the public health challenges of today. And what he notes is that although measles is often first, it's a harbinger for what's to come. So I'll start with a little bit of a story, everyone loves an origin story. So the pox this is of course, anyone who knows Romeo and Juliet knows that the pox on the Montague and Capulet houses was actually the plague, not measles, but it works. So measles is zoonotic in origin. So it diverged from rinderpest, which is a paramyxovirus that primarily affects cattle, was eradicated globally in 2001, and itself originated from a virus called Peste Petit Ruminant virus, which affects petit ruminants like sheep and goats, and is still in circulation today. So we don't really have a whole lot of history before the 900s. I know I'm going to say the 1900s, but the 900s about measles. It doesn't seem to be differentiated between the various pestilences and pox. However, in 901, a Baghdadi physician by the name of Muhammad al-Razi is generally credited with describing and differentiating measles from the other kinds of pox, including smallpox and plague. We think this was one of the first instances of a student plagiarizing his mentor's work because there were actually two books written, the Book of Smallpox and Measles. Dr. Al-Razi is generally credited with writing the one in 1901. However, his mentor seemed to have written the same one by the same title 30 years earlier. What Dr. Al-Raza wrote is that smallpox is a transitional state from childhood to adulthood during which the blood ferments like wine. Measles is a disease caused by too much bilious blood. He probably didn't get that right, but he got the last part right, which is the best thing to do during this phase is to stay away from the patient. So we have our description and differentiation of measles in about 901. In the 11th and 12th centuries, measles is further differentiated from rubella, and there are multiple outbreaks worldwide. In the 13th century, Gerald of Carmona translates the Arabic works into Latin in the New World and coins the term morbilis from morbis, which is sickness. We then sort of skip over to the 1600s. In 1657, there's an outbreak in Boston of measles. In 1670 and 74, well-described outbreaks in England and Scotland. And in 1693, the Venerable Dr. Sydenham coins the phrase measles, unclear whether it's from misère, meaning sickness, or from measles, meaning rash in Dutch. In 1896, Henry Koplik describes his pathognomonic enanthem. And in 1945, actually without the benefit of an MRI, Ludo van Boger describes subacute sclerosing panencephalitis, which is a devastating cranial neurologic complication of measles. So measles was described in 901, I knew I was going to do that. But unclear whether it actually became an entity then. So I just thought that this study was really cool. It kind of made me want to go back and be an evolutionary microbiologist. When we think of measles, we typically, or many infectious disease, we typically describe something called the R0, which is a measure of infectivity. There's also another measure of infectious disease that we sometimes talk about, which is the critical community size. So this is basically the population number needed to support persistence of a disease. If a population is lower than that for a particular disease, then the disease won't take hold. In general, lower numbers than that mean that people are either immune because they've recovered from the disease or dead, depending on the kinetics of the disease. So the critical community size for measles is broad, about 250 to 500,000 in a population. A few hundred years BCE, the economic and political infrastructure was such that there were settlements in North Africa, India, China, some in Europe and in the Near East that would allow, began to surpass the critical community size for measles. So some German and French researchers in 2020 took a look to see if they could really figure out when measles diverged and became its own disease. So they did this really cool study. They took some historic specimens of rinderpest. They took some historic and current specimens of Peste petit ruminant, and then they took some lung specimens that were preserved in formalin from various museums, including the Berlin Museum. This is one of the specimens up on the upper right-hand corner of a young child who died of measles pneumonia in 1912. Apparently, and there are probably people in the audience who know more than I do about this, but measles is an RNA virus, and RNA is actually fairly hard to extract, so they actually had to go get tissue. So they purposely looked for early specimens. Anybody know why? Why they stopped in around 1954, 1960? So they were looking for the natural history. And as we'll see in a couple of further slides, 1954 is when the vaccine strain was developed. So there's no longer a natural history. So what they ended up doing through the magic of molecular sequencing and Bayesian modeling is they recalculated the divergence of measles, of of RPV from PPRV and measles from rinderpest. So what they ended up finding was really interesting. So they found that rinderpest and PPRV actually diverged about uh, 3,500 years BCE. And measles itself diverged from rinderpest actually closer to about 600 BCE. So the panel on the right here is also kind of interesting. So this dotted line is the CCS of measles. These sort of squiggly lines are cubic spline regression lines for what the community size was at various time points for Mesopotamia and the Western world, East Asia and South Asia. And the red line is when rinderpest and measles diverged. So you can see that around the time when the critical sample size was able to support measles is about when it diverged. So now that we sort of know about the history of measles, I'm going to talk a little bit about the history of the measles vaccine. So in 1757, a Scottish physician by the name of Francis Home does what's popular at the time called variolation. So this was before Jenner and his cowpox thing. So back then, they used to take a sample of a smallpox lesion, for example, inoculate it onto the skin of another person, and hopefully that person would get an attenuated form of the disease. It worked sometimes, didn't work all the time. So Francis Home basically tried this with blood and tried it with measles. And it was a miserable failure. Everyone got measles, but it was proof of concept that measles was infectious and and you could isolate it in blood. So fast forward to 1954. So John Enders is a physician scientist over at Harvard. And does anybody know what was happening in 1954 in terms of vaccinology? Lots of stuff. So vaccinology was really taking off. And they were about to be scooped by the polio vaccine. Jonas Salk, who was not at all from Harvard, was going to scoop them with his vaccine for polio. So Dr. Enders sends his pediatrician graduate student over to the Fay School in Massachusetts, where there's an outbreak of measles, and he has him sample a bunch of students' bloods. So he samples one particular student, an 11-year-old by the name of David Edmonston, remember that name for later. And basically then what he tries to do is he tries to attenuate the virus. So he successfully grows it from David Edmonston. So going forward, this particular strain is either called the Enders strain or the Enders-Edmonston strain or the Edmonston strain. And Enders attenuates the virus. So his idea is he's going to grow it in a series of cultures to try to basically weaken it. So he first tries it in human amnions. He swears up and down that he got these placentas from the Brigham next door and that all was fine. He passes that through a human amnion cell culture several times. He then takes that strain, passes it through human kidney cells a bunch of times, and then he goes on to chick embryos and passes that same virus through several times. So that he feels has attenuated the virus, made it safe for administration. So in 1958, he gives this vaccine to 11 children in Massachusetts. In 1960, he gives the vaccine to 23 children in New York. And this was actually a very big success. So he gave there was a Willowbrook, which I'm going to talk about a little bit later, is an institution for developmentally and physically disabled children that's now closed in New York. And there was an ongoing outbreak of measles. So he specifically took 23 children that he knew to not be infected, gave them his vaccine, and indeed, when they compared to children who didn't get the vaccine, none of the children got measles. So at this point, like is common, industry takes over. So Merck comes in, takes over research and development. Maurice Hillerman, who's probably the only good guy in this story at all, is the head vaccinologist over at Merck at the time. And he sort of looks at this virus, he sort of looks at the vaccine and notices that the side effects are pretty profound. So he figures out that if he gives the dose with a small dose of IG, it mitigates some of the side effects. So he goes on to try to attenuate the strain more. He successfully does that by passing it through some more chick embryos, and he ends up with what's called the Morantin strain. I don't know whether that's proper pronunciation, but it stands for the more attenuated Enders vaccine. So in 1963, the measles vaccine was licensed with some IG. In 1968, the Morantin strain was now the present vaccine strain, and he developed this into a vaccine named Attenuvax. In 1971, the MMR was created with the same strain. In 1978, the MMR was introduced, recommended for school entry. It was still, as you may have seen on my vaccine record, recommended at 12 months of age. But now there was a further push to try to get people to get the vaccine before they got, to ensure that people got the vaccine before they hit school. And then in 1998, we had an event. So this is the most, oops, there we go, sorry. This is the most space that I'm going to give to this paper by he who shall not be named. So this paper was retracted in 2010. It was billed as being one of the biggest disasters in public health, and certainly felt to be some of the origins of vaccine hesitancy. I'm going to show you in the next couple of slides that maybe we haven't done such a good job of setting the stage for this paper, and this paper just may have compounded what was already going on. So it was a case series, 12 children aged 3 to 10 with intestinal symptoms and a history of normal development followed by a loss of acquired skills many years earlier in most cases. They were admitted to the hospital for 1 week. He did psychiatric evaluations, colonoscopies, MRI, EEGs, LPs under sedation, TFT, CBC, long chain fatty acids, stool for O&P. He did genetics. And what he found was that basically everyone had a normal MRI. And they had this sort of garbage term called an lymphoid nodular hyperplasia. And oh, by the way, they'd all gotten the MMR vaccine 24 hours to 2 months prior to their loss of acquired skills. It's never really, these children came from a gastroenterology clinic in England. Not, again, the majority of authors have retracted their input. And it's generally felt that the data is both cherry-picked and falsified. So the conclusion that he came up with was that the presence of this intestinal inflammation and absence of detectable neurologic abnormality in our children, because they were his children, are consistent with an exogenous influence upon cerebral function, and he deemed that the MMR vaccine. I was in medical school when this came out, and it was, I don't know if anybody else was around when this came out and practicing medicine, but it did cause people to think. So I sort of brushed over the history of, when I gave you my brief history of the measles vaccine, but let's just take a little bit of a deeper dive here. I said that in 1958, the measles vaccine was given to 11 children. It was given to 11 developmentally disabled children who were institutionalized in Massachusetts. There is no documentation that either they or their parents were consented for this, which was a highly experimental vaccine at the time. The 23 children who received the vaccine were in a school called Willowbrook in New York, which is subsequently closed after a very young Geraldo Rivera went in with cameras and showed really the horrifying conditions that many of the children lived in. It was, however, a big source of vaccine trials back in that day. So there is good evidence that these parents
Good, you can
were
take them off. Thank
coerced.
you.
Again, the conditions in the school were terrible. These parents were offered for their children to be in them. But however, it was one of the only schools in New York that really serviced developmentally and physically disabled children. So there was a huge waiting list, and parents were offered a spot in the cleaner unit, which was the experimental unit. And the rationale that was given at the time was basically that these kids were going to get sick anyway, and that we were doing them a favor by providing these products to them. Hilleman later goes on to say that, not only was the procedure unethical, but the vaccine itself was as toxic as hell. Some children had fevers so high they had seizures, and he didn't actually call it a vaccine. He called it an inoculation. And again, history doesn't particularly help us when it comes to setting the stage for vaccine hesitancy. So there was something called the Cutter Incident in 1955. About 200,000 children in 5 states were enrolled in a polio vaccine trial, in which the process of inactivating the live virus proved to be defective by the Cutter company. They didn't follow Salk's instructions for attenuating the virus. Within days, there were reports of paralysis, over 40,000 cases of polio, 200 children with paralysis, and 10 deaths. And Willowbrook is also notorious for performing between 1956 and 1972 hepatitis A and hepatitis B vaccine, or I should say hepatitis A and hepatitis B research, where these children were deliberately infected with hepatitis A and later hepatitis B in an effort to differentiate between hepatitis A and hepatitis B, which we didn't really know much about at the time, a response to immunoglobulin and subsequent vaccine development efforts. Saul Krugman, who was a pediatric infectious disease doctor and the inceptor of the hepatitis A and hepatitis B vaccines, was voted the president of the American Pediatric Society in 1972. And in 1983, as a co-recipient with Dr. Hilleman, was awarded the Mary Lasker Public Service Award. Interestingly enough, Dr. Hillebrand called both Dr. Krugman and his vaccine administrations highly unethical and extremely disgraceful. And that Public Service Award is now the Bloomberg Woodard Public Service Award. It's never been revoked, and it's still given out. It was given to Planned Parenthood. It was given to the Gates Foundation recently. So just one more fuel for the fire. So in 1991, the CDC and Kaiser Permanente conducted a clinical trial in Los Angeles, predominantly in about 1,500 Black and Latino infants, testing a new strain of measles, the Edmundston-Zagreb strain, as opposed to the traditional measles vaccine. The consent forms didn't say that this particular strain was experimental or unlicensed, which it was. The study brochure actually sounded like it was giving people a lollipop. So this vaccine has been shown to be effective in younger children. Over 200 million children around the world have received this vaccine, but Los Angeles County is the first place in the United States where it's being offered. What the study noticed was that there was an increased incidence of death in girls who received the higher dose EZ product. It was a dose escalation. In Haiti and Guinea-Bissau, the study was stopped for safety reasons in 1991. We don't believe the participants were not notified at the time. The CDC did acknowledge the lack of disclosure in 1996, but I don't believe there are any reparations or apologies. So it's understandable that in looking at vaccine decision-making factors, especially in racial and ethnic minorities, especially in communities that have been affected by these kind of trials, that many participants cite historical medical exploitation as a barrier to trust. So just a little bit about measles now to lead up to Dr. Patel's portion. So in 1954, because of the MMR vaccine, because of the push to vaccinate before school, and because specifically of some policies that Jimmy Carter put in place, he was very pro-vaccine and put a lot of money into public health, specifically into poor children's health, both rural and urban. Cases had dropped to about 1,500, and there was only 1 death. However, we did have a change of administration, and that often has a delayed effect. As well, there was only, at the time, we were only recommending one MMR vaccine, which we know, although the vaccine is highly effective, it's not completely effective, especially with a single dose. So between 1989 and 1991, there were about 55,000 cases in the States, a huge resurgence.
Let's just see if
11,000
this,
hospitalizations,
see what
123
happens. Thank
deaths.
you. All right, have a good
So
day. You too.
Reagan
day.
and
Go.
Bush
Go.
pulled back a lot of the vaccine policies and money
hear
for
it?
public health, specifically in urban areas, that
You're
Carter
kidding
had
me.
put into place. And there were outbreaks in Philadelphia, California, Chicago, as well as in New York. When you kind of look back, you can see our own Joel Foreman, who some of you know, he's the medical director of our inpatient units. Was around during this time, treated a lot of kids. And over those 3 years, there were 5,000 cases and 21 deaths. When the CDC came in and took an analytic look, they found that less than 50% of children in New York City were vaccinated for measles by the age of 2, and only 25% were up to date on all their immunizations by age 2. So some responses were that the MMR vaccine was changed to a two-dose schedule in 1989, and in 1984, Bill Clinton signed into law the Vaccine for Children, which provides children who are underinsured, uninsured, or on public assistance or public insurance vaccines for free, ensuring that all children less than age 19 are vaccinated. So this is the last story I'm going to tell you, and this is a story that's told by Paul Offit and a bunch of other people, including Bob Ross. I'm going to let you decide what you think about how this particular outbreak in Philadelphia was handled. So from 1990 to 1991, Philadelphia had about 1,400 cases and 9 deaths. Many of the deaths and about a third of the cases were centered around in a 2-month period around 2 local churches, the Faith Tabernacle Congregation and the First Century Gospel Church. So on January 16th, 1991, someone calls the Department of Health and says, I'm a member of this church. It was the Faith Tabernacle Congregation. There are a bunch of really sick kids. Our congregants don't believe in any kind of medical care, vaccines, any kind of medical care. I'm worried. The gentleman who took the call was a pediatrician, an epidemiologist by the name of Bob Ross, and he also tells the story. So he said, okay, I'm going to think about this. So on February 7th and February 10th, the popular press reported that 2 children, both church members, died from measles. So at this point, he and his team from the DOH went to visit the church leaders, and they said, he said, can we help you? Can we vaccinate you? Can we get you some medical care? And the faith leaders said, no. We think that this is a trial put on us, from God, and that we believe that our faith will prevail. So he doesn't really like this response. So on February 12th, he goes to the court. He gets a court order to at least visit the households of this congregation and visit the children. He's not allowed to touch them. He's basically allowed to look from the door. 2 days later, on February 14th, the popular press reported that 3 more children from the church died, including one that he had visited, but not been allowed to examine. So at this point, he gets a court order to examine the kids. And who do you think he gets to do it? He calls his old institution. I think he was at CHOP, but he also called St. Chris's, called the chief residents and said, hey, do you have any residents and interns that you can spare to come and help me with this investigation? They were all trainees, can you imagine, going out into the community. And by then there was no Bell Commission, there was no ACGME. You were allowed to, in fact, you stayed post-call, and there was 1 in 3 call. Bob Ross kind of describes this saying, yeah, they went post-call into the houses. So the CDC also arrived in Philadelphia. Why? Because at this point, we know that the Death rate of the mortality of measles is about 1 in 1,000 cases. Here, it was about 1 in 35. So there was concerns maybe this was a more virulent strain. As it turned out, it was not. It was just that many of these children were actually medically fragile from not having medical care for many, many years. And also the complications of measles, pneumonia, dehydration, they weren't seeking medical care for those things. So they then went back to court, got a court order to hospitalize critically ill children against parental consent, and subsequently a court order to vaccinate the children against parental consent. The church groups go to the ACLU because what they were doing was perfectly legal in the state of Pennsylvania. There is a religious exemption for vaccines. The ACLU refuses to take the case. They say this is a third party. You're not making a decision for yourself. You're making a decision for your kids. We're not getting involved. On March 4th, 8 children were immunized. So here's on the right is the epi curve, basically. And you can see by the time that they forced immunization, the outbreak was basically done. 486 total cases, 6 deaths within 2 months. We blame REM for the inception of the outbreak into Philadelphia. We believe that a teenager from Spain got measles abroad, went to an REM concert and spread it to the entire Philadelphia. So remember David Edmonston? So he was the 11-year-old who had his blood taken and is now his measles strain is in all the vaccines, including to this day. So as it turns out, in the 80s, he was an anti-vaxxer. He has since rescinded that, but to this day, he says his children and his grandchildren refuse to be vaccinated based on some conversations that he had with them back in the 80s. Okay, so we have to do the pathophysiology. You're all getting CME for this. So that was what I consider to be the fun part. Now I'm just going to go over a few slides of physiology. So measles is spread by the airborne method, inhalation of respiratory droplets or airborne particles. It infects the dendritic cells and alveolar macrophages via the SLAM receptor, in case that's ever on a board's exam later. The infected immune cells travel to the regional lymph nodes, leading to viremia about 2 to 3 days after infection. It then disseminates to the spleen, liver, thymus, and bone marrow. And you get a secondary viremia around day 5 to 7, which then spreads systematically to the conjunctiva, respiratory mucosa, the skin. It's not particularly a neurotropic virus, but it can be, and the CNS in some cases. There's a delayed activation of the innate immune response, which allows for this viral dissemination, and the typical kind of adaptive immune responses rein it in. It does require a T cell response as well as B cell for IgM and IgG. And recovery, again, depends on cell-mediated immunity, not just humoral responses. So the clinical presentation is such that the incubation period is a mean of about 10 to 14 days, a range of 7 to 21. There's a classic prodrome of cough, coryza, conjunctivitis, and fever caused by cytokine release and initial viral replication. Koplik spots are an anthem, is a viral replication in the buccal mucosa with cell infiltration. And then when the rash appears, that's the onset of immune-mediated clearance. So the important thing to remember about that is that in our immune-compromised patients who may not have immune-mediated clearance, they can shed for a very long period of time, and they often present with atypical disease. They may present with no rash, an atypical rash. Primarily, they present with very severe pneumonia. The complications are typically pneumonia, either by direct viral cytopathic effect or secondary bacterial superinfection, and then several encephalitides. So there's an acute measles encephalitis, which is basically by direct viral infection of the neural tissue, a post-infectious measles encephalomyelitis, an ADEM, basically caused by the measles virus, something called measles inclusion body encephalitis, which is active measles infection in specifically immune suppressed patients who can't clear the virus. And that can persist and is really quite morbid. And subsclerosing panencephalitis, which is occurs primarily in children who develop measles prior to 2 years of age, especially prior to 1 year of age, and results from persistent defective non-infectious viral particles that persist in the CNS. And this is also almost uniformly fatal. One of the also wonderful things that measles does is it causes what we call immune amnesia. So measles is displays lymphotrophism. So preferentially infects and induces apoptosis in CD27 positive memory B cells, central and effector memory CD4 positive and CD8 T cells, leading to depletion of the adaptive memory pool, reducing capacity to mount secondary response, loss of your antigen-specific antibody repertoire, up to 60 to 73% of reduction in existing B cell receptor and antibody diversity post-infection, as well as decreased antigen-specific IgG levels. Overall IgG levels are normal because you now have high titers of measles IgG. Impaired class switching, affinity maturation, and long-lived plasma cell and B memory cell generation. So basically, you're susceptible to many secondary infections, including other vaccine-preventable diseases for up to 3 years after infection. And now I'm going to fast forward to Dr. Patel.
A lot has happened in the last couple of weeks, so the timing of this talk couldn't be better. NASEM has put out on July 11th an urge to our public health authorities at the national level to do something about vaccine hesitancy. Chuck Schumer asked for President Trump and RFK Jr. To put out a public health emergency, and the Journal of the New York Times has this as a headline that measles cases hit the highest total since the US eliminated the disease in 2000. New York City is especially vulnerable for emerging and re-emerging infectious diseases. We have an exquisitely high population density. Many of us experienced what this assisted in driving some of the COVID-19 outbreak that we saw here in early 2020. We have a significant immigrant and asylee population. It's estimated 23% of our New York City population is foreign-born. We have high rates of medically vulnerable patients. Think about how many transplant centers, cancer centers, and how many hospitals are on First Avenue as you go down. We have an unfiltered surface water supply. We are a destination for many travelers and international commerce. In fact, we had 65 million travelers to New York City last year. And we will acknowledge that we are always a potential bioterrorism target. There are 3 measles outbreaks in the last 10 or so years that really inform where we are post-elimination status. Obviously, there were other outbreaks, but I specifically want to focus on California, New York, and what's happening in Texas. And this highlights the importance of public health and the power of public health, the risk of anti-vaccine sentiment, and the risk of domestic and international travel. How many of you remember the Disneyland outbreak, where Disneyland was no longer the happiest place on earth? MMWR was published earlier, but this outbreak, the index case that was recognized was an 11-year-old unvaccinated child that the only risk they had was, well, I should say the 2 risks they had was that they were unvaccinated, but that they had visited Disneyland in late December 2014. In the end, this ended up being 667 cases total, spanning 7 states and Mexico and Canada. In fact, it was 110 cases in Canada. It sparked an international conversation. It was a sensational storyline. It was rapid spread through vulnerable population, children, not eligible or only partially vaccinated, and it highlighted that risk of travel. 75% of the children involved in this particular outbreak where vaccine status was known, of those 76% were not vaccinated due to personal belief or delay in schedule. And so this was when the state of California, who had a law in place that kids going to daycare in K through 12 needed to be vaccinated, removed their personal belief exemption, and it was the first state to do so. This was an outbreak that hit close to home. The 2018-2019 New York, and I say New York City in this particular slide, but it was about a 50-50 split between Rockland County and New York City. So over 1,100 cases in this area threatened the US elimination status. So elimination is defined by the WHO as 12 months without ongoing transmission. The index case for this particular outbreak was an unvaccinated child returning home from Israel 9 days before rash onset. In New York City alone, there were 648 cases confirmed between September 30th, 2018 and July 15th, 2019. The majority of cases, both in Rockland County and in New York City, were amongst the Orthodox Jewish community. Here in New York City, the majority of cases were in Williamsburg, with spillover into Borough Park and Crown Heights and other areas of Brooklyn. The median age was 3 years old, but actually as the outbreak progressed, you saw the age rise. And in Borough Park, toward the end of this outbreak, the median age was about 13 years old. And what this showed us, there were numerous chains of transmission. There were worldwide outbreaks in Ukraine and Israel, and so we had multiple importations. It was all the same strain, and actually the same strain that was highlighted in many of the outbreaks that Dr. Duchon talked about. There was non-adherence to public health recommendations and deeply entrenched beliefs amongst the community. 5.7% of children developed pneumonia, 49 patients required hospitalization, 20 required ICU care. In fact, there was an exposure event because a child was admitted to one of our neighboring children's hospitals with the prodrome and then developed measles in the ICU. So they subsequently had to do a contact tracing within an ICU within a children's hospital. There were no deaths, but I do want to warn you, we're less than 10 years from this event. So we'll see if any of the later manifestations of measles infections will come to light. On the left is a very fancy, glossy anti-vax propaganda pamphlet that was sort of spread throughout the Orthodox Jewish community, both in Rockland County as well as in Brooklyn. It was written or authored by a group called PEACH, Parents Educating and Advocating for Children's Health, and it linked vaccines to autism, which we know has been disproven over and over again, infertility, which we know is not true, and that components of the vaccine were actually not kosher. In response to this, the New York City Department of Health, with stakeholders from the community, published A Slice of Pie, Parents Informed and Educated, where they brought culturally competent and culturally appropriate evidence-based information to the community. And this is something that I think a lot of us struggle with today, understanding what drives someone's reasoning for not being vaccinated. These are examples of Mount Sinai Health System's response back then. So we did focus on the 4 zip codes that the New York City Department of Health and New York State Department of Health focused on. We had this signage at all points of entry. We actually leveraged Epic so that if someone hailed from these zip codes, you would get a banner across that said measles risk. So you would have it at the top of mind that perhaps these individuals were at higher risk for measles and your threshold for diagnosis should be low. We actually limited some visitors, especially to our most vulnerable population. So think about our neonates in our level 4 NICU, where we did look at vaccine status, and we actually limited some children from visiting their siblings. On April 9th, 2019, a public health emergency was declared in those zip codes, specifically in Brooklyn. It required all persons living and working in those 4 zip codes to be vaccinated within 48 hours unless they demonstrated immunity or a valid medical exemption. Many individuals were added to that epi curve because they had their titers drawn and it demonstrated that they were actually recovered from measles rather than getting vaccinated. It required parents and guardians of a child over 6 months who live or work within those zip codes to have their children vaccinated. Both temporary restraining orders and preliminary injunctions were denied, and 57 unvaccinated individuals received summons or fines. And you can see the dotted red line in this graphic is Williamsburg vaccination rates between 2017 to 2018 between the ages of 12 to 59 months. And the red line with all of those events and sort of paternalistic moves by the New York City Department of Health, how they increased vaccinations and were able to stem this outbreak. So here we are today. 2025, Texas, New Mexico, Oklahoma, and any of you following this, it has spilled over into North Dakota and Kansas. Transmission amongst close-knit communities, that's how the MMWR refers to it. It's the Mennonite community specifically, with very low measles vaccination rates. Since 2008, New York City and New York State has required all vaccines given to children be placed in our immunization registries, which are readily available through Epic. You'll be able to ping the vaccine registry and see any vaccinations given in New York City or New York State, or if our providers actually put the vaccine records into Epic, it will transmit to our immunization registries. In Texas, it is voluntary, so the vaccination rate is mostly unknown in these cases. I did some back of the napkin calculations of the 3 public health departments listed here, and there's been at least 868 cases across these states. 809 are unvaccinated or unknown. There have been 106 hospitalizations and 3 deaths, all in individuals who are eligible to get 2 doses of the MMR vaccine. And because, as Dr. Duchon said, it's usually 1 death in 1,000, this suggests this outbreak is much larger than what has been reported. I love the Journal of the New York Times. They have fantastic graphics, and this is one that was published last week, and the big red circle is Gaines County, but you can see there are growing red circles all over this map with lots of blue dots of little clusters of cases. An outbreak is 3 or more cases, and right now, if you were to look at the news, there are outbreaks in neighboring New Jersey and elsewhere close by. So this is from last week. The CDC should update their numbers today, and we know it will be higher. So last week, we have 1,288 cases, and it's only 6 months into the year, almost 7. We way surpassed where we were. And remember, 1,100 plus of those 1,200 cases in 2019 are from New York City and New York State. So we have work to do. Globally, and this is from April, so the United States will be dark blue the next time this comes out. We're in trouble. So Canada, 3,703 cases with 1 death. Most of those cases are in Alberta and Ontario. Mexico, 2,597 cases with 9 deaths. That's in, this year alone. And in Europe, in the last 12 months, over 18,000 cases. And although you're looking at probably the countries in the graphic on the right and thinking about where patients travel, especially here in New York, we obviously have a lot of individuals who travel to India and Pakistan to visit friends and family. If you were to think of Europe, there were 686 cases in the month of May, with over 100 in France, 100 in Belgium, over 50 in Italy, and over 50 in the Netherlands. So I want you guys to think about your travel plans and make sure you check whether your friends and family have up-to-date vaccination or evidence of immunity. Paul Offit is a vaccinologist out of CHOP. He's someone we all followed very closely during the COVID-19 pandemic. And he is also a member of the BLA of the FDA still. I checked yesterday. Vaccines are the victim of their own success. We've largely eliminated the memory of this disease. I'm going to look in this audience. How many of you were born in 2000 or after? Interns, right? How many of you have actually seen a patient with measles? I'm not talking about a picture. If that kid walked in, I will quote one of our ED physicians, if that kid walked in the ED, we would recognize it immediately. Okay. Measles is not just a childhood illness. I know I'm speaking to adults and adult providers. Over 34% of the cases that have been reported in our individuals above the age of 20. 11% of the hospitalizations that have been reported are individuals over 20. One of the deaths was in an unvaccinated adult, and at least 2 of the now 7 cases reported in New York City have been in individuals above the age of 20. And in full disclosure, one of them was here, one of them was at Elmhurst. So your sort of patient population. So now we brace for more cases. It's not if, it is when. And healthcare providers, such as all of us in this room, have little experience in recognizing and managing measles. That long incubation period works against us, and the prodrome is relatively nonspecific. You are very lucky if you see a complex spot. Unfamiliarity leads to missed and delayed diagnoses, allowing for transmission and ineffective counseling regarding measles-associated morbidity and mortality. And controlling the threat of measles requires achieving and maintaining high vaccination rates. The magic number is 95%. Communicating with parents, guardians, and patients who are reluctant to receive vaccines is very challenging. I do want to quickly sidebar to our measles response. This is a concerted effort with ambulatory emergency medicine, infectious diseases, infection prevention across our health system. And we follow the identify, isolate, and inform framework. I just want you to remember that in the back of your mind as you travel to different areas of your healthcare spectrum, whether it's your clinic, whether it's inpatient, whether you're rounding in the ED. Those early symptoms I won't go through because Dr. Duchon described them. The rash generally occurs 3 to 5 days after that prodrome onset, starts at the face, behind the ears, spreads down the body. It's usually macular-papular. Patients are infectious, and this is the kicker, 4 days before and 4 days after that rash onset. So you can imagine individuals coming with the prodrome, and you're like, oh, do you have the flu? What's going on? You've exposed everyone in your waiting room, including the staff. Risk factors for measles, this is why we ask those questions when you're going to a doctor's visit. Our triage nurses in the ED ask every patient who comes to the front door these questions. Have you traveled? Have you had exposure to measles? And all of us should be checking our patient's vaccine status. Ping that CIR or NICIS in EPIC. Isolate, it's highly infectious. It is the most infectious disease we know of. And Dr. Duchon talked about the critical population, but there's also the R naught. The R naught ranges between 12 and 19. COVID was 1 to 2. Ebola is like 1 to 3. Patients and escorts should be masked, placed in private rooms with the door closed, preferably an airborne isolation room. I think we have one in our ambulatory footprint across this health system, so private rooms for ambulatory, and don't forget to wear your N95 respirator to provide basic care. We have 2 more airborne isolation rooms coming online in our newly renovated ED. And I do think one of our ED partners is in this audience, and thank you for your support in making sure we keep patients and staff safe at our biggest point of entry to this hospital and this health system. In terms of inform, please escalate to infection prevention. We're on call 24/7. And we also ask that you report to the Department of Health and Mental Hygiene. If you're outside of New York City, that would be the New York State or Public Health Department for your county. All testing is performed through them. So it's a nasopharyngeal or oropharyngeal PCR in the viral transport media, as well as a measles IgG and IgM. Please don't just do an IgM alone. And our Department of Health colleagues assist with contact tracing. And if you can't, because of name changes and misprints and spelling, can't get into that immunization registry, they can help. These are all the things, and special thanks to Elizabeth Rosen, Ron Tamler, and Brendan Connell from our EPIC Informaticist team. This is a work in progress. We have signage at all of our entries. You should check if you go to a clinic whether there's some sort of signage that suggests someone can self-identify that they have fever, rash, cough. We have best practice alerts or OPAs that go off to triage and front desk saying, hey, this person might have measles. This is a fake patient taken care of by Doogie Howser, you will see this flag in red that someone either was exposed or being tested for measles. If you're an outpatient, you'll see these biohazard symbols, and red means measles. And then our patients, if they do respond with a sort of combination of symptoms, exposure, and travel, they will themselves get an alert that says, hey, maybe you want to call before you come. And if you do decide to come, please wear a mask and tell us that you're here. I'm going to pause here. If you do not have the First Line app on your phone, please use this QR code to put it on your phone. It's infectious diseases at your fingertips. It's easily accessible. Not only will you figure out how to treat a UTI, you will also understand this framework, and you will also have the contact information for the Department of Health. It's on every desktop launcher. It should be on your phones if you just got a phone, but this has been really vital to making sure we can get you guidance to your fingertips, whether you're in the firewall or not. And I really want to thank the Mount Sinai Health System for seeing this as a priority and helping us continue to maintain this application. Post-exposure prophylaxis, it's super complicated. This is also on the app. So if you have the app, you'll be able to peruse this. But it's not just complicated, it is time sensitive. We have to get to these patients who may have been exposed, and staff who might have been exposed within 3 days and no later than 6 days. There are two exposure pathways. We either give someone a dose of the MMR or we offer them immunoglobulin. Immunoglobulin is for our youngest children who cannot get vaccinated, as well as those who are immunocompromised. This study, case control, is from 2013 by our City Department of Health when there was a smaller outbreak here in New York City, where they looked at who developed measles after getting MMR and immunoglobulin. For MMR, it was about 83% effective. Immunoglobulin was 100% effective for an overall 93% effectiveness. And this has been supported by a recently published meta-analysis looking at a lot of different studies in vaccine. Immunoglobulin probably offers greater short-term protection. It is very expensive and resource intensive. We do have to bring those individuals into our ED to get IM immunoglobulin or IVIG. It can be affected by the concentration of measles-specific antibody in the product, and it has been noted over time as the donor pool becomes younger, there are decreasing concentrations of measles-specific immunoglobulin in the product. So this is a moving target. Dr. Duchon mentioned vaccine for children. It was established, as she said, in 1994. And in 2023, 54% of children in the United States were eligible for VFC. Vaccines prevent morbidity, and just to give you numbers, in looking back at these children over time from 1994 to 2023, vaccines prevented 508 million cases of illness, including 104,000 cases of measles, 3.2 million hospitalizations, including 13,000 measles-related hospitalizations, 1.1 million deaths, including 85 deaths from measles. It was a direct savings or estimated savings of $540 billion and societal savings of $2.7 trillion. We're in trouble. So as I said, New York State has required from daycare and K through 12 vaccines since 1991. But until 2019, they allowed for personal exemptions. What we've noticed is we have pretty high vaccination rates compared to the rest of the country for individuals entering those systems, daycare and school. But we have decreasing vaccination levels for children less than 2 years of age, and they should have at least had 1 dose on board. So statewide, it's about 81%. And if you look at New York City on the right, there are pockets, including north of us, where vaccine rates are about 60 to 80%. So why are these conversations difficult? It's multiple. So one, omission bias. People would rather not do something and have something bad happen than doing something and having something bad happen. There's a lack of understanding of numerical risk. You can see in this graphic that was recently republished in the New England Journal last week or the week before, when there's a nice review article about measles that demonstrates in the column in the middle the risk after natural disease of all of those complications that Dr. Duchon mentioned, including death, and the risk after vaccination. But individuals have a tendency to pay attention to the numerator, 30 adverse events, versus the denominator, 1 million doses given. And then there's ambiguity aversion. There's a desire to hear something's 100%. Nothing in medicine, and we all know this, is 100%. We don't say 100% for any intervention or any treatment. Also, people have a tendency to look for information that confirms their bias, right? Like you see your pediatrician maybe a few times a year. As your kid gets older, maybe once a year, unless they have, an illness du jour, depending on the season. We as adults see our doctor once a year for our wellness credit, right? You can spend all day doom scrolling the internet and try to figure out, can I find something that supports my belief? Also, we're here. I just want to tell you, it's been less than 6 months since inauguration. So 176 days. The Advisory Committee of Immunization Practices has existed since 1964. So for 60 years, it's been the cornerstone of our national immunization strategy. It informs the standard use of FDA authorized vaccines. It recommends to insurance companies what to cover, including VFC. It is a panel of experts that actually have overlapping terms that reviews the most up-to-date evidence for vaccines and the monoclonal antibodies we offer for RSV prevention. And those are universally adopted by the CDC until this year. So on February 13th, our new HHS secretary was confirmed. On April 5th, the FDA CBER director resigns. On May 1st, with no forewarning, COVID-19 recommendations changed abruptly for children and pregnant persons. On May 6th, a new director was announced. For the first time ever, on May 30th, that new director overrides the FDA BLA recommendations. That's where Paul Offit sits without consultation. On June 9th, all 17 members of the ACIP panel, that includes individuals that work at cancer centers, pediatricians, and the like, were dismissed. 8 new members of the ACIP announced, including known anti-vaxxers. It was a very lively June 25th through 26th ACIP meeting. There was one notable pediatrician who Dr. Duchon has worked with in the past that was a voice of reason, or at least tried to be a voice of reason, but many public health authorities and institutions and societies who normally had a seat at the table chose to boycott, including the AAP, the Infectious Diseases Society of America, ACOG, as well as the Society for Healthcare Epidemiologists of America. And on July 7th, there's been a multi-party lawsuit against HHS Secretary and HHS based on those COVID-19 vaccine recommendation changes. So here we are, 176 days later, broke 60 years worth of effort. But there is the Disneyland effect. This actually happened back with the Disneyland outbreak. When you looked, even Google said they had a 50% increase in the search of measles and measles vaccine. Right now, if you were to look at Google statistics, you will see in February there is a spike, and New Mexico is the driver of that spike. So this is the power of public health. New Mexico has taken this on. The purple line is 2025 vaccinations compared to the orange line is 2024 vaccinations, and you can see the rapid increase in vaccinations in New Mexico. So in conclusion, measles can be eliminated again, but we have to work as a collective. Failure to vaccinate is what drives these outbreaks, not failure of the vaccine. We're ramping up efforts, and kudos to our pediatricians who really are the front line to ensure our eligible children are vaccinated. We can have a longer conversation about what's happening internationally with delays to vaccination due to COVID, as well as pulling of funding to support vaccination efforts abroad. We have to work together to maintain trust for immunization. We hope we offered you some advice in recognizing measles and having a lower threshold to consider the diagnosis. And please take this opportunity to revisit your practices. And the last slide goes to Dr. Duchon.
Expedite this. I know we're over time. So anyone who's ever read James and the Giant Peach, the Charlie and the Chocolate Factor series. So Roald Dahl wrote those books. He was very medically knowledgeable. He, in 1962, a year before the measles vaccine was approved, received a note from his daughter Olivia's headmistress, school headmistress, that there was a measles outbreak at her school. Their son, Theo, was medically fragile. He had a VP shunt and had been in a car accident, had been hit by a car when he was young. So they got a stock of immunoglobulin for him. But his pediatric, which was the treatment for the preventative strategy for measles at the time, but the pediatrician told them it's okay, let the girls get measles. It'll be good for them. It's a rite of passage. So Olivia, their eldest daughter, contracted measles. By day 4 of her rash, her fever curve was improving and she was able to play chess with her father. On day 5, she woke up and complained that she had a headache. She didn't want to play, and she described her fingers as being clumsy when she tried to make some little paper figures. At 11 a.m., her pediatrician visited and said, just let her sleep. at 4 p.m. she was having seizures. The pediatrician came and then the ambulance, and Roald Dahl accounted the rest of the day in a green journal, as he's a author that he labeled Olivia. The short story is that they got to the hospital. He felt frozen. There was a small single bar electric fire on a wall, an old man in the next room. A woman doctor went to the phone trying urgently to locate another doctor. They tapped her spine. It's encephalitis. He went in to see her, said, Olivia, Olivia. She raised her head slightly off the pillow. He told the doctor to consult experts, call anyone. He called the man in Oxford. He listened. There was not much that could be done. Several hours later, he got a call from the hospital to come. I'm afraid she's worse. He got in the car, got to the hospital, walked in. 2 doctors advanced from the waiting room. He asked, how is she? And they said, I'm afraid it's too late. I went to her room. The sheet was over her. The doctor said to the nurse, go out, leave him alone. I kissed her and she was warm. I went out and I said to the doctors, she's warm. And he subsequently dedicated both James and the Giant Peach and the BFG to her. He also in 1986 wrote a letter to the public, which was taken up by the NHS to distribute to parents on vaccine hesitancy, because he said there's no child that has to die from measles like my daughter did. Thank you.
Thank you both for an extremely powerful grand rounds. We are over time, but if anybody has any questions, perhaps you can come up and speak to our speakers directly. Thank you.